Hey everybody, welcome to the 10th installment of the Inside JABA Series, which I suppose is also session 176 of the Behavioral Observations podcast. In this episode, Dr. Linda LeBlanc and I are joined by Drs. Jenn Austin and Dithu Rajaraman to discuss the paper they co-authored with Drs. Holly Gover, Tony Cammilleri, David Donnelly, and Greg Hanley. The paper is titled Towards Trauma-Informed Applications of Behavior Analysis, and you could find it in the latest issue of the Journal of Applied Behavior Analysis. So in this episode, we covered how this large group of authors became connected in the first place, what motivated them to write this paper, what literatures outside of behavior analysis inform their points of view, how this paper, in Linda's parlance, is a big idea paper, why behavior analysts may shy away from contending with this issue of trauma. We talk about the core commitments of trauma-informed ABA, the parallels between compassionate care and trauma-informed ABA, and so much more. So I really hope you enjoy this episode as much as I did. And if you haven't done so already, I recommend going back into the catalog and checking out session 131 with Dr. Camille Kolu. It's you can consider it your basic course in trauma-informed ABA, or at least it's a good conversation that gives that gives the listener a good background on this stuff. So I highly recommend checking it out. I think it's a great companion episode to this one. And as a matter of fact, I've been in contact with Camille and hope to have her back on the podcast to explore this issue in more detail. So if you're interested in the ways in which adverse experiences can affect the practice of behavior analysis, stay tuned because we're going to be doing more content on this. As with other shows in the Inside JABA series, this one is available for continuing education credit. So if you'd like to learn more about how to access those podcasts for your professional development needs, go to behavioralobservations.com and click on Get CEUs. There's a little tab right at the top. It's easy to find. Also, if you enjoy the Inside JABA content, please consider subscribing to JABA. Compared to other journals, it is really a bargain price-wise, and it really helps to support the mission of the Society for the Experimental Analysis of Behavior. So, having said all that, I hope you, again, enjoy this conversation as much as I did. So, without any further delay, let's get right to this 10th installment of the Inside JABA series.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Hey everybody, welcome to what I think is the 10th iteration of the Inside JABA Series podcast. And before introducing our guest, I just want to say a special thanks to Linda LeBlanc, Editor-in-Chief of JABA, for partnering with Behavioral Observations to do this. It's been a really, really fun, and it's something I look forward to every time we have one of these things. So I think it's a really helpful contribution to the field. So Linda, thank you very much. And I'm pleased to introduce our guest today, Drs. Jenn Austin and Dithu Rajaraman. And we are going to talk about a recent paper, a paper they're about to publish in the upcoming issue. And it is titled Toward Trauma-Informed Applications of Behavior Analysis. So Dithu, Jenn, Linda, welcome. It's great to be chatting with you guys today.
Thank you, Matt. And let me thank you right back for partnering with SAYAB to produce this Inside JABA podcast. It's just one more way to get our literature to behavior analysts everywhere. And you do us a great favor by giving us the means to do that. And we are very excited to highlight an article that will be appearing in our winter 2022 issue of JABA. This is a discussion paper, and I think it is a great example of one of the big idea papers that I love to be able to highlight. And so I am excited to hear, as I always am with a big idea paper, how did the big idea come about? How did you decide to write this paper? What how'd you get connected, and what were you interested in putting in front of people?
Right. So I had been working within foster and adoptive care for a while, as well as in alternative education schools, where you come into contact with a lot of kids who have experienced substantial early childhood trauma. And in my work, I noticed that these children and their families were shaping my practice and the way I thought about and did behavior analysis. And I happened to be chatting with Greg Hanley one day about some of these observations. And I mentioned that I wanted to write a paper that might provide some preliminary ideas about applying behavior analysis with this particular population. And he said that he and some of his colleagues, including Dithu and Tony Cammilleri, Holly Gover, and Dave Donnelly, were also grappling with some of these same issues. And he asked me if I'd like to collaborate on a paper with them.
And from our side of the camp, we had recently completed a couple of studies that were investigating ways to approach challenging behavior, both in everyday context as well as in the mealtime context. And we had been evaluating some procedures that kind of explicitly avoided physical management and that really gave children a lot of autonomy with how to engage with their treatment. We called some of those interventions the enhanced choice model, or like mealtime without tears. And as we were disseminating those processes, it's something really resonated with folks that were working with individuals who've experienced trauma. We got question after question about, hey, do you think that this would be appropriate for a client who's experienced trauma? Hey, is this commensurate with trauma-informed care? And it was those questions that we got from practitioners out in the field and from caregivers that really made us look to the trauma-informed care literature to see, is there a point of connection here? Is there something to say about trauma-informed care as it relates to ABA? And we were so thankful for those prompts because it really helped us, open the door to explore an entire area of human service delivery, a framework for doing so that really prioritizes sort of safety, physical and emotional safety, and the well-being of the client. So we were really excited to dive into that literature and potentially write a paper for the ABA audience about it.
Well,
and one last little point of connection I should mention, if I can just brag about my institution really quickly. I'm at UMBC, University of Maryland, Baltimore County, and I'm a junior faculty. I'm an assistant professor, and they have this wonderful program called the Eminent Scholar Mentorship Program, which is like you show up and they're like, hey, pick a scholar in the field that you admire, and we will slide into their DMs and ask them if they want to mentor you for a few years. And so it was a little bit more formal than a direct message, but the university reached out to Dr. Austin, who was a clear pick for me, and she graciously agreed to serve as my eminent scholar mentor. So that mentorship program is very open-ended. It's kind of choose your own adventure. And fortunately, these things kind of happened sort of at the same time, where we were like, we have this mentorship relationship. Let's also maybe work on this paper together. That'd be a great way for us to kind of a medium through which to do mentorship.
I love that. And, it really speaks to the importance of networking, mentorship, and professional conversations, not only with other scholars, but with the audience for your work. You have the perspective of what you'd like to say to people, but when you can also get some information and some feedback about what they're hearing and what they're experiencing and what questions they have, it can actually change how you're thinking about your own work and its application. So I often find that these big idea papers, they evolve through conversations and connections that you have with other professionals. So thanks to both of you and all of your colleagues for making the effort to write a discussion paper, which is no easy feat. And particularly to have a Dithu, let me just say this. You are a junior colleague. You've got a first authored discussion paper in JABA, and that is fantastic. So congratulations to you. Like, you should You should really feel proud and accomplished because you are accomplished.
100%.
Thank you so much.
Couldn't agree with you more, Linda.
And I would be remiss as if to not give credit to all the co-authors, because it truly was a group effort. It wasn't one of those papers where the lead author wrote it and then everybody gave comments. We from the initial development of the idea all the way to the end, I was just the lucky one who drew the straw to be first author, I suppose. But I will take the compliment. Thank you very much.
Well, that's a humble way to put it, but we'll let you stick with your story. So, I think for a lot of behavior analysts, this is going to feel like a relatively new area of engagement. What do you think has made it somewhat difficult for the behavior analytic community to dig in with this topic?
Yeah, I have firsthand experience with this because while I was in graduate school, I will never forget this. I was at a conference down south and I was deep in my radical behaviorism course. So I was this kind of uppity grad student who thought that I knew everything there was to know about behavior. And there was a researcher at this regional conference who was talking about trauma with children and adolescents. And this researcher was really emphasizing the notion that trauma gets hardwired in the brain and it just sort of sits there. And therefore, we have to deal with it. And I remember being and a member of that audience rolling my eyes thinking that's not a behavioral approach to anything. What this doesn't jive with how we've been taught to think about why behaviors occur and what motivates them. So it was during the debrief of that conference with some trusted colleagues that I was like, and this person was talking about trauma, but it was so anti-behavior analytic. And I had some trusted colleagues kind of correct me or at least point me in the direction of, well, okay, what does behavior analysis have to offer for individuals who've experienced trauma? What would you have said if you were up there on that stage? And it was another moment of self-reflection and to think, is this an area of behavior analysis that we've sort of been willing to just subvert because it maybe hasn't fit neatly into our conceptual system? I don't know, Jenn, do you have any thoughts on that?
Yeah, I'd say that years ago, I probably had much that same perspective that you had, Dithu, as an audience member at that conference. And I even remember working in a residential unit for adolescents with emotional and behavioral disorders when I was a grad student. And although I look back now and I realize that those kids probably had some pretty horrific histories, we never even considered them when designing and implementing programs for those kids. And it wasn't until years later that the way I thought about and behaved with respect to trauma started to change. And I think a big turning point for me was working with children who had experienced abuse and neglect in the first year or so of their lives, but were then pretty quickly adopted into loving families who largely did what we would recommend parents do in terms of employing behavioral principles. However, even in the face of those kind of tried and trusted behavioral strategies, many of those children continue to have significant behavioral issues. And I thought, something is going on here beyond the immediate environment that's contributing. And I think that that's a big part of the difficulty for behavior analysts, and it's something that we address in the paper, is that we are trained to focus on the here and now when it comes to identifying controlling variables. But for people who have experienced trauma, those remote histories are incredibly important in understanding the etiology of behavior and what particular antecedents and consequences, not just their effect on behavior, but what those things mean to those individuals. some students and I recently conducted a survey of behavior analysts to get their perceptions about their knowledge and skills with regard to trauma. And we had about 400 responses to the survey. And what we found was that a significant proportion of the respondents reported working with clients with known histories of abuse and neglect, but a substantially lower proportion reported being confident and even asking about those histories. So I think there's also a bit of uncertainty around whether it's even in our remit to be asking about those more remote histories if we're going to be kind of focusing on current contingencies. We also found that about 80% of the sample thought that behavior analytic strategies probably need some adaptations for individuals who have substantial trauma histories, but less than 30% of them felt that they had the knowledge and skills to effectively work with those populations. And I think this probably brings us on to another barrier, which is also addressed in the paper, is that it's difficult for behavior analysts to embrace strategies that aren't backed up by some data. And full disclosure, there's really no objective evidence that taking a trauma-informed approach improves client outcomes. And there's certainly very little in the way of systematically evaluating the use of behavior analytic strategies for children or adults who engage in trauma responses. There are a few exceptions in the ACT literature, but by and large, we don't tend to report trauma histories when describing participants. And that makes it difficult to know whether some of the strategies that we read about in our journals are actually effective for this population.
Mm-hmm.
Well, do you think, before Linda, excuse me just one second, I want to just kind of jump in real quick. Do you think that it might have something to do with the various ways in which, in other words, the ways in which someone can experience and come in contact with traumatic events is so varied, everything from very acute events like a car accident or a specific instance of abuse versus, say, like the vicarious trauma that a therapist might have, and treating, a wide variety of patients with these types of issues and things along those lines. So it may not necessarily be a singular phenomenon that you're looking at, but a rather a quite a diverse way in which people can both acquire these repertoires that are influenced by trauma and present in various ways depending on how those things shake out.
Yeah, I think that's a great point, that experiencing a terrible event doesn't necessarily make it a traumatic event. It's the response that makes it a traumatic event. And I think that's another difficulty, is that those responses are often highly idiosyncratic across people, and which brings in a lot of additional complexities into how you're going to address those problems.
Mm-hmm. Well, I applaud you both for tackling an area that has primarily been talked about outside of the behavior analytic literature. And, when I started doing work on things like perspective taking and problem solving, these kind of phenomena that have primarily been studied in the cognitive literature far more than the behavior analytic literature, I fully expected to get my hand slapped by behavior analysts that were going to say, like, why are you studying those things? And And I think we have to be careful not to throw the baby out with the bathwater. The fact that another discipline or another theoretical orientation has explored something doesn't make that thing part of the other orientation. Like, yes, certainly cognitive scientists have done far more of the work on memory, but that doesn't mean we can't have a conceptualization that's behavior analytic. Thanks, Dave Palmer. Similarly with language. And so, I think in this instance, the trauma response, we have to keep in mind, is a biobehavioral response. And that's part of what makes it complex, is you not only respond to the event, we tend to have these ways of representing the event to ourselves by reimagining, by talking about. And there's actually literature that suggests people can get re-traumatized when they are talking about their prior trauma. So, and a lot of that work is actually done in the behavioral literature by some of my former colleagues at Western Michigan University, like Rick Spates and Amy Noggle. So you decided to dig into this, and it really speaks to the notion that when we talk about the person by environment interaction, part of what is included in the person is their longer learning history. And it's not just right now, the current environment. What we're looking at is how that current environment influences the organism with this learning history, and none of them are identical. So, hello, idiosyncratic. This ought to be easy to figure out. But that kind of thing gives you a whole career worth of things to explore. So I get that you probably had to explore primarily outside of the behavior analytic literature for this. Can you talk about a few of those literatures and some of the high points that if someone was willing to go adventuring and exploring a bit, things they ought to check out?
Yeah, well, we pretty much read everything we could get our hands on with regard to frameworks for trauma-informed care and prevalence of trauma and responses to trauma. And there are some really good resources out there, including publications by the CDC and the Substance Abuse and Mental Health Services Administration, and they provide good examples of what trauma-informed care might look like across different contexts. We try to summarize some of the key points of those publications in our paper. But to be honest with you, I think if I had to recommend some readings to behavior analysts who are looking to skill themselves up with regard to trauma, I wouldn't start with the literature that we review in this paper. I'd actually start with a couple books. One is a book called The Body Keeps the Score by Bessel van der Kolk. And then the other is Toxic Childhood Stress by Nadine Burke-Harris. And there's a wealth of research summarized in those books with regard to trauma prevalence and biological and behavioral effects of trauma. But what I think is maybe most compelling in those books in terms of kind of coming to grips with a trauma-informed approach are the real life experiences of the victims of trauma that are captured in those books. And I think for my money, a big part of what behavior analysts maybe need to understand a little bit more is how trauma is experienced by the people that they work with. And I think that's the first step to really being trauma informed.
I wonder if you could walk us through what some of those core features of trauma-informed care are. We talked a little bit about trauma and about the trauma response, but how would you know that something was trauma-informed care if you tripped over it?
That's a great question. That's a really great way to phrase it, because I think it allows us to start by suggesting that trauma-informed care is probably a continuum. When you think about all of the services that you provide to a client or all of your clients, they can probably line a continuum of being less trauma-informed to being more trauma-informed. But based off of all of the resources that Jenn mentioned that kind of outline their own frameworks, we sort of distilled 4 primary commitments or core commitments of trauma-informed care. Number one, it's important to acknowledge the potential impact that trauma can have on an individual. And that's simply stating out loud that trauma may have an impact beyond just the stimulus and response of what's happening in the moment. Is the first step to being trauma informed. I suppose it's sort of like it opens the door for you to acknowledge or to engage with these other commitments of trauma informed care. So number one is acknowledging trauma and its potential impact. Number two is ensuring physical and emotional safety, or as we said it in the paper, ensuring safety and trust with the clients with whom we work. Number three is promoting choice and shared governance or collaborative treatment planning with the clients with whom we work. So any opportunities in which you have to promote the clients being able to choose among multiple options and also to be able to contribute to their treatment development, that moves us toward this along the continuum toward more trauma informed. And then a final step is to emphasize skill building. I've outlined 4 steps, but I'd like to maybe take one step back and kind of define trauma informed care, broadly speaking, which is it's more of a preventative, or you might even say like a universal framework that a behavior analyst or an agency can take on. Say we're taking on a trauma informed care approach. And what that would mean is that all of your services are geared toward minimizing re-traumatization in clients that may have experienced trauma and facilitating their participation in therapy. So those are sort of 2 overarching goals. We want to minimize experience of trauma and then also facilitate participation. Those 4 commitments help achieve those goals, you might say. Those 4 commitments are sort of actionable steps that agencies can take that move, that help clients feel safe and feel willing to participate.
I want to kind of, I guess, piggyback on that. So if I was like the CEO of, some large ABA provider, and I engaged you as a consultant to come into my agency, what are the specific practices in the treatment room? I get the principles, the commitments, maybe the strategies, if you will, but for the behavior analyst who's listening to this right now, who is, on their way to work and they're going to go work with clients today, how do you make those principles as kind of actionable as possible or as relevant as possible in terms of the day-to-day activities?
Yeah, I'll start by saying that's a very hard question because of our kind of paucity of evidence. We don't have a ton of vetted strategies that we've said, this is trauma-informed care. We tried it, it worked, and everybody loved it.
Well, the reason why I asked this question, because I do see people put on their business website, we are trauma-informed. I practice trauma-informed, and so and I'm not trying to be a crank here or a contrarian.
You're totally being a contrarian, but that's why we love you, Matt Sikori. So
okay, all right. So I'm just gonna be a crank here. But no, I'm not really. But I what I want to, like, this all sounds awesome, and it would be even more awesome, to the extent to which we can make these principles and distill them to be more actionable. And of course, there's client individuality. Everyone's needs are different and things like that. So in many respects, I am asking you an impossible question. So there's your out, but you could do with that with what you will.
I think that it's helpful, and I hope that as we continue talking that we are able to bring up more than one example, but I think it's helpful to maybe use an example and talk about how you may or may not approach it from a trauma-informed lens. So I think about a client or a student who has experienced some trauma on the school bus, and therefore even transitioning to and from home to school is a severely traumatizing event. One that, upon saying, hey, it's time to get on the bus, we might see a whole lot of problem behavior. Maybe we all work in settings where we've experienced this client before, maybe not. But that if we even take the first core commitment of trauma-informed care, acknowledging trauma and its impact, there's a difference between saying, listen, I know that the school bus is tough, but we got to get on the bus and go to school every day. There's just no questions asked, versus saying, I acknowledge that this experience was traumatizing for you. Maybe we scale back and we work on reintegrating you into that school bus environment. We maybe work on emphasizing the skills that it takes to approach the school bus without fear, without reproach, without excessive problem behavior, before we reintroduce the demand or the expectation that a learner ride the school bus. So to me, it's the difference between feeling as though we need to push through something because it's just those are the expectations that life has in store, versus acknowledging, oh, this particular expectation is too much right now. It is potentially traumatizing, potentially re-traumatizing every time the school bus shows up to the front door or whatever, to the end of the driveway, and behaving with respect to that sort of acknowledgement. If we can acknowledge that event might be traumatizing, we might change our focus, change our priorities, and maybe even change up our treatment strategies in order to help the student succeed in that context. It doesn't mean that we remove the school bus altogether. We can all acknowledge that life happens and that we need to take the bus to get to school, but the time that we take in acknowledgementville allows us to develop strategies that emphasize skill building, that promote autonomy with the learner, and that all while ensuring safety and trust.
Well, and I think that how we talk about things really governs how we make decisions about them. And so if we're thinking of it as non-compliance on the school bus, as opposed to maybe, if we know the circumstances, an understandable, strong, fear-based response, we're going to be far more likely to choose a evidence-based anxiety intervention like graduated exposure, rather than just a straight extinction procedure, which falls more on the flooding end of those anxiety treatments. So it may get us thinking about some even other parts of our behavioral treatment literature for different components.
I think so. Yeah, I think that's a really great. I've started to sort of conceptualize things like functional communication training as a sort of exposure therapy. You are introducing some sort of aversive EO often especially when you're talking about teaching a escape response, and it's the way in which we present those EOs that might be a graduated exposure versus a flooding tactic.
Yeah, absolutely. Well, I think, Matt, I am a crank too. So, right. That's why we have so much fun on these podcasts. But I will say people tend to like new, shiny, and if it's got letters and an acronym, that's even better. And I have tended to avoid those kinds of areas. Because I think people get that excitement almost gets them attached to that particular area. So I've done plenty of research on naturalistic treatment strategies. It doesn't mean that that's what I do. That what that is behavior analysis. So it's part of what I do, right? Mm-hmm. I've now done some work in the area of compassionate care. But that's not what I do. What I do is behavior analysis, and I do it in a way that we can describe as this. So all of these terms, they're labels that we use to describe maybe certain ways that we make decisions, certain variables that we emphasize or that strongly control our intervention choices. And for me, that notion of collaborative decision-making with respect to treatment, whether you are collaborating with the parents of someone who is young or maybe does not have a great framework to communicate what their choices are, or the client themselves, like that's a real parallel that I am excited to see behavior analysts. We've got to give them multiple exemplars on that path towards don't take the expert model. You you may be an expert, but you're also disposable. These are people who are accessing services to improve their lives, and they are going to have their lives when you are long gone. If you can collaborate with them about what they experience and what they do and how much they want to do that and how comfortable they are, you're going to, in all likelihood, end up with people who feel more responsible for their actions in that treatment, and with a treatment that is probably going to be around when you are gone. And I think we have a long way to go with respect to that. So to me, that's a parallel a little bit between this notion of trauma-informed care and some of the work that's been done on compassionate care. Do you guys, am I just yamming about a similarity you don't see, or do you see these things as compatible?
We definitely see them as compatible, and I really love the paper that you wrote with Bridget and Melissa on compassionate care. And as you guys note in the paper, I think it really flags up some of the skills that we often aren't taught in our behavior analytic training programs. And as I mentioned earlier in the discussion about what I'd recommend to behavior analysts who are interested in being more trauma-informed, I think that skill of developing and displaying empathy for someone who has experienced trauma is critical. And we are compassionate when we can use that information to develop strategies that take that context into account, really similar to Dithu's school bus example. I can give another example. I worked with some colleagues here in South Wales on a case involving a young woman, we'll call her Lucy, who was living in a residential unit for young people who were transitioning from foster care but weren't quite ready to live independently. So by and large, these are typically developing 18, 19-year-olds who need some additional support before independent living. And Lucy had experienced both physical and emotional abuse as a child from people who should have kept her safe. And she engaged in a lot of suicide threats and self-harm. And actually, Lucy accounted for the largest number of emergency service call-outs in the whole of the county where she lived. And assessments, it won't come as any surprise, indicated a clear attention function. So in addition to several other strategies, which I won't talk about right now, one of the strategies that the behavior analyst at the service implemented was an NCR procedure where staff had a schedule on which they would check in and engage with Lucy at irregular intervals and ask her, if she wanted to engage in particular activities, get a cup of tea or go for a walk or go to the supermarket. But the idea was just to give her this regular attention. And the treatment plan was working brilliantly, and we saw some great reductions in both self-harm and suicide threats until Lucy overheard staff talking about the NCR intervention and talking about the schedule. And when she heard that conversation, she, and this is a behavioral term, freaked out. Property destruction, verbal aggression, suicide threats, the lot. because for her, this intervention meant that no one really cared about her and they were just pretending to like her. And for a kid with trust issues like Lucy, the intervention felt like a massive betrayal. And I think that really speaks volumes about how critical it is to put yourself in someone else's shoes, not only with regard to what they have experienced in the past, but what you are designing for them to experience in the future. And the primary lesson learned from Lucy was the importance of transparency in establishing safety and trust, so that one of those core pillars of trauma-informed care. And now that transparency is standard practice of that service, and residents are involved from the outset of treatment in planning interventions and weighing in on what they think will or won't work for them, and making sure that they understand the logic behind interventions that are designed for them. And I think that's incredibly important because it shifts the focus from doing behavior analysis to someone to doing behavior analysis with them.
Jenn, that's an excellent example. One of the questions I had that came to mind is, and it kind of dovetails with another aspect of the paper that you guys wrote about. There's a considerable amount of page space that's devoted to choice making. And so with regard to this particular case, so I think there's a couple of themes that come up here. One is, assent or consent, or, whatever the age, I suppose, of the person receiving services might be, or their guardianship status or what have you, as well as choice, and then the transparency you speak of. Could you maybe walk us through what a conversation might go like when you're trying to explain a non-contingent reinforcement type of protocol to someone receiving services, knowing that they'll probably, I'm maybe putting words in your mouth, and correct me if I'm off base here, but knowing there might be some apprehension about that, like you guys are paying attention to me because it's your job, and blah 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 blah. I can imagine some of the possible responses you might get. I guess where I'm going with that is, how would you make the case to the client to do something like that when there's going to likely be some level of pushback?
Yeah, and I have to say that I have the advantage that with the majority of clients that I work with, we can have those kinds of conversations, which is a little different from, a lot different from the populations that a lot of behavior analysts are working with. And, they're also working with these people with substantial trauma histories. I think that one of the first things that we do in that situation is to have conversations about what that person would want to be different about their lives, because I think from the outset, you have to start with values. So what's important to them? And then you can start having some conversations about the ways that you might facilitate that. And, if I were working towards implementing an NCR intervention, then we may have a conversation about how if people were there for you more consistently, would that feel better? Would that feel like you were less alone and you had people with you? Because one of the values that kids might talk about is, I want to have friends. We often ask kids, what would you like to be different about your life? And we had one kid who said, I would like to have a dog. And you think about, what value can you build around, I'd like to have a dog? Well, then the follow-up question to that is, well, what would that give you? And what he said was, it would give me a friend. And that gave us something to work with in terms of identifying what was important to him. And I think that's the hook. The behavior change has to be important to the individual. And that's why we've moved much more in our work to more things that are self-management type interventions, because as Linda said, this is someone's life and we're not going to be around forever, and we've got to start facilitating those skills that help people respond effectively in their own lives. So I think starting with that conversation about values is incredibly important, and then you can start suggesting what might work to help them achieve what they want in their lives.
You used that word friend, and I think that's probably a big part of why this young lady freaked out is there wasn't a conversation with her about, you want to have a future where you have friends and you spend time enjoying things that you can do with those people. And, we're not your friends per se, but we're people that care about you. And we're going to be doing some of that stuff so that you learn how to do it. I think the notion is they probably behaved as her friend. She was describing them as her friends, and your friends are typically not paid to read a program and implement it with you. And so, of course, as professionals, we have to be the ones recognizing that we are the steward of the perception of that relationship and keeping it as a therapeutic relationship, but talking directly and honestly, particularly with individuals who have language and are going to be describing the things around them in terms that are comfortable to them. My very first experience in psychology was working as a volunteer in a shelter for out-of-home placement for children suffering abuse, neglect, what have you. And I was much closer to their age than anyone else in that facility. And one of the things that the team there really coached me on that I had to always be cognizant of is they're going to behave as if you're their friend and you are a caring person who's coming to try to help make their life better during the time that they're here. You have to think about yourself that way, and you have to put them in a position to think about you that way. Mm-hmm. And that's not a full overlap with this word friend. So I think that notion of, I thought you were being my friend, and now I realize you're like following the policy or some crap like that. That's where that notion of a betrayal comes from. And I think I often think we get that same feeling of betrayal. And that's why families of children with disabilities exit ABA services. Like, I thought you were really going to involve me. You asked me all these questions at the outset of services about what I care about and what I value and what's the history. And then all of a sudden, I'm not having conversations and input like that anymore. So it's about how you set the tone of that relationship and, creating that safety and consistency. That's a word that you used, Jen, that really resonated with me, that I'm going to behave the same way throughout all of our collaboration with respect to treatment.
And I think that the commitment to transparency is another choice point that we can make as practitioners or as an agency. And that regardless of the language repertoire of our clients, if we commit to saying, I'm not going to try some sort of intervention without first at least doing my best to describe it to you, I think that sets the occasion for us to actually behave quite analytically. Because if our clients are protesting the NCR that we just described to them, that protest in and of itself is a data point. It tells us that we have work to do to find a procedure that's going to be both effective and acceptable to the client. So to me, I think that I've been in a situation before where I've worked on a team and we've been kind of putting together some sort of treatment plan. Sometimes it involves like maybe some type of a response cost. And we're like, oh, I don't think Timmy's going to like this, but we put it on put it in the behavior plan the next day anyway. And to me, I think that is a cultural shift that we can all embrace and make that is entirely commensurate with everything that Linda and Jenn have just said, that it allows from the outset, it allows our clients to have a voice in whether or not this treatment is jives with them.
And I think that, we've got a very nice literature on how to give families that voice in selecting between evidence-based, function-based interventions, and also clients. And, to be honest with you, I have always loved that literature on using the concurrent chains procedure to get data with respect to what versions of treatments clients like. To me, that is such an everyday doable thing. We don't always think about our treatment as one option in the universe of possibilities. We think of it as our option, which makes it the option, unless we're careful to prompt ourselves to think of all of the other possibilities. And that if there are multiple reasonable options, why wouldn't you get information from the client about what they would prefer? Now, you don't put the unreasonable options on the menu, right? But, though, if there are multiple approaches, to me, that's something that you could do every time you work with a client. Is if you've got two options, get a little bit of data. Would you like to be taught this way, whether it's by video modeling or live modeling or structured or play-based discrete trial teaching? Or would you like FCT or NCR with a side of garlic mashed potatoes? Whatever it is. We like these kinds of choices. And I'm glad that you focused on that literature because I see it. It really is one of those, Matt, you were asking, I'm a behavior analyst. What could I do today? When I get to work, number one, you could think about, okay, I'm doing this treatment. Well, what are the other reasonable options? And you could try to find a way to get some data from your clients or their caregivers about not only which of these do you like, but why do you like that? If in fact, they have the language to describe some of that to you.
Great. Thanks for adding that. So I know we're kind of like knee deep in treatment talk here. I'm going to try to take us back a little bit into the conceptual realm here, just for a moment, because as a former Pigeon Lab, lackey, I want to ask you guys, in addition to the agreements or the commitments to trauma-informed care, there's other stuff that I think behavior analysis has brought to bear on this that goes back decades. And I'm talking about, what are some conceptual findings from the EAB research, especially, in the punishment literature and things like that can help from a basic concepts and principles standpoint, help behavior analysts frame how they view trauma.
Thanks for asking this question, Matt. I think it's really important, and it'll only help us be better prepared to serve our clients if we're able to make these connections. I'd like to start by saying that I don't think that you need to be well-versed in JAB to recognize that your client is in distress right in front of you, and to potentially make the choice to back off and allow them to find some safety as opposed to kind of working through something for the sake of working through it. To me, that doesn't require, you don't need to have memorized Catania. That said, this is another situation where I sort of have used examples to try to teach and illustrate maybe how some of our conceptual system plays a role here. And I'm reminded of a client who I worked with when I was back in Massachusetts at the New England Center for Children. And it was a residential program. And this client was pretty severely impacted by their multiple diagnoses and was a pretty dangerous guy. So his lifestyle was quite restricted. But one trip that he would earn at the end of any week where he was perfect, where he didn't hurt anybody, is he would earn a trip out to the local Stop and Shop. It's a grocery store up in New England. I know Matt knows all about that. And he'd go into the Stop and Shop. He'd go into a Dunkin' Donuts and he'd get his favorite drink, a colada or an orange juice, what have you. And I had been working with this client for a little over 2 years, and he'd earned that perfect week trip every once in a while. But that perfect week trip was a heavenly hour for this guy because there was just nothing was going to get in his way. And even, we would typically wear a lot of protective equipment while working with him, but we would let our hair down and we would just go into the store because it was the happiest hour of the week oftentimes. And so one such week, I was sort of one of his staff people kind of shadowing the trip. And I was driving the van and we pull up to Stop and Shop and we're taking the long walk from the back of the parking lot to the store. And I think I've set the stage enough. He's always very happy. As if from out of nowhere, this client just chomps down on his teacher, just bites real hard, really aggressively, and just starts attacking her to the point where we need to kind of escort him to the van and terminate the trip. And so I'm kind of out handing out these community cards. We let people in the community know, hey, we have everything under control. This is a specialized school. Please call this number if you have any questions. And when I get back, I notice that this client is completely flushed, like his body color is completely different from what it was. And he's panting and sweating and he's basically yelling, no more dogs, no more dogs. I don't want any more dogs. And we're just like, what is he talking about? There were no dogs in this parking lot. So things finally calm down. We're all buckled. We're getting ready to head back to the school. And as we kind of make this turn in the parking lot, he starts yelling it again, no more dogs, bye-bye dogs, bye-bye dogs. And we notice that there's a woman wearing one of those fuzzy Ugg boots. It's really fuzzy. And here's my interpretation. It's not a behavior analysis. It's a behavioral interpretation. My interpretation is that this client saw this Ugg boot, looked like a dog, and a whole bunch of trauma came up and resulted in perhaps an operant response that characteristically results in escape from a particular environment. We discovered after the fact that this client, when he was young, was mauled by a dog at a park. And that's why he didn't travel to parks ever. He hadn't had graduated exposure to any sort of stimuli that even resembled dogs throughout his whole life. And when students are in residential programs, there's a lot of times where some of that information slips through the cracks. That's 4 or 5 years on. So those of us that were working with him at present had no idea about this history. We just knew that he didn't go to parks, but we thought that the grocery store was okay. And, so I've tried to use this as a teaching tool to talk about kind of potentially respondent operant interactions. I think Linda, earlier, you said it's a biobehavioral event that occurs. And it seems reasonable to me to infer that the stimulus Ugg boot somehow elicited or occasioned some sort of really, really traumatic response in this client that resulted in extraordinary behavior that didn't really calm down for a while. And so it helps me think about the fact that these respondent operant interactions are around us everywhere, every day. And to a point that you made earlier, Matt, the transient nature of trauma, that it can come up with any such stimulus, any such event for any learner. There's something to me that's wildly aligned with the behavior analytic worldview that stimuli have that function trumps structure, that it's not about what something looks like, it's how that thing affects our behavior. And so to me, this thing as benign as an Ugg boot having that effect on a client tells the whole story.
Just enough stimulus features to elicit that same very strong response.
Yeah. I mean, there was no mistaking it. There was some fight or flight happening. I mean, he was sweating, he was crying, he was all sorts of jacked up. And to me, we of course, you'd want to be familiar with the concept of stimulus generalization, the notion of stimulus control, and how stimulus control works in a respondent sense as well as in an operant sense. But I don't know. I've found that instructive in the past.
Yeah, that's a great example. Thank you for sharing that. And it's that interplay of operant respondent conditioning that I think it's important to remind people of, is that, in addition to the commitments that you've already described, there's these basic principles in our literature that can inform our practice that have been around for literally decades.
Mm-hmm. And I think there are some terms that are often used in talking about trauma that may feel a little uncomfortable to behavior analysts and may make them disregard some of those things. For instance, you'll often hear either family members or people who have experienced trauma talk about trauma anniversaries. So, and essentially what they're talking about is the anniversary of some significant event in their trauma history. I was working with a client recently, and his adopted mother had talked about his trauma histories around Christmas. And it's all those things that should be nice and fun about Christmas, like putting up the Christmas tree and playing Christmas music and those types of things. But there were features of that were, of course, correlated with his previous trauma, and understanding that context and being able to behavioralize that term trauma history and explaining it with respondent and operant principles, I think is really important for behavior analysts to understand.
Great. So I want to get back into the treatment realm here. So, but thank you for indulging me on that little, conceptual foray there. But so I was recently in a meeting with a special education administrator in one of the largest school districts in my state, and we were talking about various students of need in the district and how we're going to serve them, and just as an offhand comment, she said, well, some of these kids are trauma kids, and which I don't like that term just as a blanket descriptor, but that's neither here nor there. And I don't, and it's what follows, I suppose, is the basis of my question. And she's like, I don't think ABA, they're probably not amenable to ABA, or that's kind of, she said some words to that effect, as if trauma was its own thing, if you will, that a behavior analytic approach was not going to be helpful. And I don't want to get people confused who might be listening to this to think that, like we're suggesting that behavior analysis is the standalone treatment for trauma. Obviously, we've talked about, the importance of other practitioners from other disciplines and things like that. So that's not where I'm saying, but obviously behavior analysis can play a role in improving an individual situation, certainly. So how would you, and I know people get these interactions happen a lot because I hear people talk about it. So how would you advise someone if they're in that situation and someone says something like that? Like, do you hop out of your seat and be like, no, you're wrong? I mean, that's what I did. But
brandish a weapon or what have you.
I flipped the table, actually. No, I'm kidding. Sorry. But in all seriousness, how would you coach someone? How would you coach a supervisor to respond in a situation like that?
Yeah, well, this question makes me sad, but I guess that I do take some comfort in knowing it's an issue that comes up on both sides of the Atlantic, because I've heard the same objections when working within multidisciplinary teams here in the UK. And one comment that I often hear is that rewards don't work for children who have experienced trauma, or a behavior analytic approach isn't appropriate for these children. And I think those types of responses might suggest that other professionals could potentially be equating behavior analysis with token economies and sticker charts and that sort of thing, which, and I would agree with them, aren't likely to solve the difficulties that these children are experiencing. I think that unfortunately, talking to other professionals about functional behavior assessment doesn't really seem to attenuate their concerns either. And if I'm being honest, I can see why that is. And it relates to the issue that I talked about earlier about perhaps too much focus on the here and now, which may disregard the importance of those historical events. So if we say that we've empirically determined that a behavior is maintained by adult attention or escape from demands or what have you, we may be satisfied that we know why the behavior is occurring, but another professional might say, okay, but that doesn't really explain why the child behaves that way. And I think what they mean is that it doesn't explain the complexity of that response or the events that made attention or escape reinforcing and what those things might mean to that child. And I think they're probably right, but also I don't think that those explanations are outside the reach of a behavior analytic account. Now, in terms of what I tell supervisees when they encounter these types of things is first, don't launch into a defensive, but rather to ask the person to tell them a little bit more about why they think that a behavioral approach might be unsuitable for this particular client. And I'd advise them to try to find some common ground if they can, because at the end of the day, every professional sitting around that table is invested in the same goals, which is a child or an adolescent or whoever the client may be, who can effectively navigate the everyday obstacles that life throws at them and to feel good about who they are and what they're doing. And finding those things that we can agree about can often open the door to considering how different strategies might actually be aligned or could work in tandem to support the goals that all those professionals have. But I think that the first thing that we have to do is listen and try to understand that perspective before we actually know what the response should be.
Agreed. And let me disclose, I sit on the board of directors of Boys Town, but I would point to that as one of the long-standing examples of effective behavior analytic treatment, where virtually every single child served by Boys Town has a history of trauma. These are people who have been in and out of foster care and had multiple living arrangements and often have complex histories of multiple types of abuse and neglect. And the approach there is very, very similar to what you're talking about in terms of trauma-informed care, creating a safe environment. Yes, using point systems and token economies, but really as a way to structure and create the expectation of consistency and reliability and always being there for someone. So I think I probably would work my way around to it. And by the way, there's actually a pretty well-known, internationally known program that's behavior analytic that does work with kids with trauma. And they happen to have a school-based curriculum if you have any interest in looking at it. So Again, it's like there's nothing new under the sun, right? I think if you were to go to Boys Town and talk with Pat Fryman and the people, particularly who run their family home program, part of which was started by many of our colleagues at Kansas, everything that you would hear would sound much like this trauma-informed care approach. It's just that we now have some letters for it.
But I do feel as though it's really not great to hear about these resources, and the more those types of procedures and processes get disseminated, all the better for our field. But I guess I empathize with the person on the interdisciplinary team who's saying these behavior analysts keep saying it's appropriate for trauma, but I haven't seen it work. And I just want to give a nod to the members of the team who are perhaps doing what they've been taught as best practice in the classroom, maybe something like a DRO with tokens for safe behavior and things like that. And I just want to appreciate that I could see how that would not solve all the complexities of trauma. But we do need, more and better dissemination of these processes that have been shown to work.
Mm-hmm.
Speaking of letters, this is one of the things I wanted to throw out there, and this is: do you guys see an additional kind of ABA accreditate or certification or training sequence and things like that for trauma-informed behavior analytics service delivery? Do you see? I don't want to put you on the spot here, but I'm going to. So, like, what are your thoughts on because it's one of those things. Again, I get back to the these practice websites that I see sometimes say we practice trauma-informed care, and people can say that, and it's and I'm not saying that people are putting those things on their website in a way that is inappropriate or anything like that. I'm not trying to cast aspersions or what have you, but do you see a benefit of having some sort of some sort of certification or other type of accreditation for providing trauma-informed behavior analytics services?
My short answer is not yet, but maybe someday. There's a paper that we cited in our discussion paper by, I think, Maynard et al. In 2018. They did a systematic literature review of studies that investigated TIC procedures, and their search returned 0 papers that met their inclusion criteria. So we're really talking about not a ton of evidence for these concepts and these commitments that we've described.
Okay.
So we are really in the naissance of a behavior analytic inquiry into this, which is exciting. But I think it would be premature to say, now that we've described, and to Jenn's point earlier, like, we wouldn't necessarily recommend going and reading all the other white papers or frameworks, because all they're doing is also just describing what these commitments might look like. We don't yet have the vetting for it. On the other side of the coin, another thing that we kind of discussed in our paper is that trauma is perhaps more prevalent than we may think. Like, we know that there's a high prevalence among children. We know that individuals with IDD and autism are at differentially greater risk. And we know that all contemporary measures of trauma, like to get a PTSD diagnosis, requires some form of verbal report, either on the part of the client or their caregiver or somebody in their life. So we don't even currently have the tools to ascertain whether or not a learner without strong language skills has experienced trauma without relying on somebody else's report. And you could see how that is a potentially precarious question to ask if we're asking parents, has your child been traumatized? So on one side of it, we have a lot of work to do to develop an evidence base to say these are the processes that we would say are TIC thumbs up. But on the other side of the coin, we can't wait till then to potentially take a more trauma-informed approach to service delivery, because I just think it's likely that every behavior analyst has worked with at least one client, if not more, who has some documented or undocumented trauma history in their past.
And regardless of whether there is a separate credential or not, part of our professional responsibility as a behavior analyst is to consistently self-evaluate our scope of competence and to do so based on our knowledge with concepts, principles, the literature, clients, supervised experience. So there's always that, even if we consider this fully within the same realm as the regulated practice of behavior analysis. Within that, you have to evaluate your own scope of competence within that regulated practice. Well, gosh, this was so much fun. Again, let me say this. I really appreciate you writing the article, submitting it to JABA, going through the process with your associate editor. That's one of the things that we kind of try to help people be aware of. I think it can be kind of exciting, but also scary to write these kinds of papers because there are no data in them. And we, we love that data. If we've been raised properly as a behavior analyst. And so I just always want to take a moment to acknowledge the fact that, you have to really kind of care about getting the word out before you take the time to write a paper like this.
Yeah. Can I add two brief things on that note?
Oh, yeah, please do.
I think that we owe you a huge debt because of the big ideas call that you made when you joined as editor-in-chief, because those words definitely were uttered. We were like, could this be a big idea paper? Like, would this
cool.
Be this criteria? That's what, and that paper was really galvanizing, I think, on our effort. And then working with Dr. Lauren Beaulieu, who was our associate editor, was the most reinforcing experience I've had in peer review to date, because maybe it's the nature of the paper. But first of all, we were so glad that it wasn't just there aren't data, so we shouldn't be having this conversation. But secondarily, Dr. Beaulieu really helping us open our perspective and widen the scope of how we were kind of conceptualizing trauma, and shared some of her own experiences as a clinician and a researcher that truly you'll see it on almost every page of the article.
Well, that's amazing. I think the editor position at JABA really is about trying to find the right AE for a paper, such that if it does get published, it becomes that best version of itself, and that the authors have a good experience in getting through that process. And so she served as a guest AE and gave you all the gift of her influence and effort. And I feel super lucky as JABA editor to work with people who volunteer their time and their effort in the editorial process. And now she'll be hearing just how fantastic you think she is, which in fact she is. So any new stuff coming up for you in this area of trauma-informed care?
Well, I think we've talked a lot today about the absence of research, and what we're hoping is that this paper may start a conversation about the research that we need to be doing in behavior analysis in this area. And in the paper, we suggest some areas that might benefit, and even starting with the inclusion of some additional measures that may capture whether we're attenuating or exacerbating trauma-related responses. For instance, keeping tabs on client refusals to sessions, or evidence of emotional distress during sessions. Those things are important. And also reporting any adaptations to the strategies that might be needed if those behaviors are occurring frequently. And I think also just when we're describing our participants, if we know that there is a trauma history, that we're reporting that, so we have more evidence around the effectiveness of what we're doing with that particular population. If I could do a little shameless plug here. Dithu and I will be guest editing a special issue of Behavior Analysis in Practice next year, which will focus on trauma-informed applications of behavior analysis. We're providing a year-long lead time for submissions for the special issue because we recognize there are a lot of difficulties in conducting this type of research, particularly in treatment evaluations. As we said before, responses are often highly idiosyncratic, treatments are bespoke, withdrawal designs are usually not appropriate, nor is delaying treatment across settings, and it's often hard to find multiple participants with the same problem that need the same intervention. So we'll be allowing a lot of flexibility in research design, so we can at least start building and thinking about an evidence base for behavior analysis and trauma-informed care.
I love it. All right. Coming soon your way from Behavior Analysis in Practice, a special issue on trauma-informed care. So if this episode of Inside JABA lit your fire, you could also be inside Behavior Analysis in Practice and submit your paper to Jenn and Dithu.
All right, folks, thank you so much for taking part of your afternoon and sharing this wonderful paper with us.
Thanks, everyone.
Thank you so much for having us.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.